Good afternoon and welcome to our Parent Guardian Talk series on My Child Can't Concentrate. We are very grateful to have Natalie Riggio and Dr. Harshasu Barot with us today. So, Dr. Barot is a dedicated and compassionate board-certified child and adolescent psychiatrist. He has completed his fellowship training at the Cleveland Clinic and joined Hackensack University Medical Center in June of 2023 to expand the need of mental health services to children. With a deep-rooted passion for helping young minds thrive, Dr. Barot specializes in working with families and children grappling with ADHD, mood disorders, and developmental challenges. His approach is both empathetic and evidence-based, ensuring that each child receives personalized and comprehensive care. His enthusiasm for innovation is not just a personal interest, but also informs his practice as he stays abreast of the latest developments in mental health technologies. Dr. Barot's blend of professional expertise, culture interest, and technological savvy makes him a well-rounded psychiatrist who brings a unique perspective to mental health care. Whether in the clinic or exploring the intersections of technology and wellness, he is committed to enhancing the mental well-being of children and families. Natalie Riggio is a board-certified behavior analyst. She received her graduate degree from Rutgers University. Natalie completed her training at the Douglas Developmental Disability Center. She has 8 years of experience working with kids and young adults with autism spectrum disorder and other developmental diagnoses. She started working with the hospital to educate team members about patients they may encounter with developmental diagnosis and also provide support for patients who might struggle in a hospital setting. In Natalie's spare time, she likes to read books and hike with her dog. So at this time, I will turn it over to our speakers.
You want to go to the next slide, Sarah? Okay, so some learning objectives that we will be going through are ways to recognize signs of concentration challenges, tips for a consistent routine, ways to create an environment to encourage focus, provide ways to identify what is contributing to troubles with concentration, and help you know when to seek some help. Okay. So, what is a BCBA? So, as a BCBA, I'm usually in a school setting. I study behavior patterns and create individualized plans for kids or adults, which include ABA strategies. So, my job usually incorporates observing students, taking data, analyzing data, then creating the treatment plans or skill acquisition programs. I just want to say a disclaimer that ABA is only covered for kids who have an autism diagnosis, not an ADHD diagnosis. In the hospital setting, I am trying to apply my usual job role into the hospital setting, which can be very different. So I'm trying to help patients learn how to cope with different hospital procedures, decrease any behaviors, work on, disrupting a routine can be very difficult for some of my kids, so I try to help them cope with that as well. Okay.
So, what is a board certified child and adolescent psychiatrist? So, myself, I did my training down my medical school, attended medical school in Georgia, did my general psych residency down in Arkansas, and decided I wanted a taste of city life. So, I took my talents to Cleveland Clinic for a 2-year fellowship, specifically focusing on child and adolescent populations. Um, I often work with patients in the clinic. I do some hospital work, but my true bread and butter is developing longitudinal relationships with my patients, my family, and helping them overcome the challenges they have, whether it be mood disorders, developmental issues. And I work with, I have a lot of overlap with some of the patients that Natalie works with as well in terms of autism spectrum disorder, developmental disorder. So that's kind of my role. A lot of times people come for me for diagnostic clarification, medication management, and kind of referral recommendations of therapies moving forward.
Okay, so how do I know if my child's struggling to concentrate in school or at home? So, something you want to start with is talking to the teachers, seeing what they're seeing at school before they're intervening. So, what are they observing before they're kind of interrupting? Such as, are the kids daydreaming, easily distracted, withdrawn or isolated, or are they acting out in class? Another thing to do is observe what's happening at home before you intervene. So, are they losing their homework assignments? Are they taking a long time to complete homework? Do they have low grades, easily distracted? It can be very different in each setting because there are different demands in each setting. And the third thing you want to do is see if there are any commonalities or differences between the two environments. So, paying attention to what your child's doing when distracted can figure out the best way to help them concentrate in the school setting and at home as well. Okay. So, some factors that can contribute to your child's struggling to focus. You want to click once, click again. There you go. So environmental factors. So the layout of the classroom or the space that they're working at home when completing their assignments can be a factor in distraction, the noise level at home or at school, the lighting of the room, the temperature of the room, many components that can kind of be distracting for them. Click again. Some social factors, so peers or siblings that are sitting around them can be distracting. Some teaching methods by the teacher might not be working for them, so they might need a little bit more one-on-one attention, or they're a visual learner, so they need more visuals incorporated more than other students. And how many kids are in the classroom? They might flourish in a smaller classroom setting depending on your district and what they can offer them.
The last component, like genetic factors, so between the social and environmental factors, a lot of those are modifiable. Genetic factors is, the cards we're dealt with from our parents, whatnot. And I'll kind of speak to that a little bit later because there is a strong genetic component when it comes to distractibility, concentration issues, and I'll speak a little bit on the diagnosis of ADHD as well.
So here are some examples on ways you can modify the environment to help decrease distractibility. So for at home, you can move your child to a quiet area if possible. Maybe if they have siblings, have them sit in their room or in the kitchen by themselves and do their work. Clear the table before starting homework. So it can be very distracting. I know myself, if I have, you know, the computer open, the iPad's on, the TV's on, it's very distracting. So it's best to remove any toys or food, any items unnecessary on the table. Closing or covering windows, especially if it's bright or if it's snowing, raining, it can be very distracting for kids. Having fidget toys nearby can be helpful. Visual reminders in sight, like a schedule, a first them board, something like that can help. Having a break area without highly preferred items. So having, a little calm down corner that just has, some items that are somewhat preferred but not loved, like an iPad or something like that, and chunking their homework assignments. So instead of you have to do all 30 questions at once, maybe let's start with 10 questions, take a little break, and then do a few more. At school, some things the teachers can try to do is move students away from peers that can be distracting. So if they're sitting near their friends and they're getting distracted, maybe moving them to the front of the room or, or moving their peers away. Making sure all distractions are put in their locker or their backpack. So, phones, toys, anything that's unnecessary for the school environment, having it put away out of sight, out of mind. Changing the layout of the classroom. I have an example on top in the corner, having the kids sit together, working groups, having visual reminders in the classroom, on the walls, having fidget toys again. You can also create a break area or a calm down area without preferred items if it's possible in the classroom. It depends. and chunking tabletop tasks. So one worksheet, then a break, very similar to at home.
I'll just add to the visual reminders component, very crucial. Like I have families that have one in their child's, bedroom, bathroom, like right by the garage, places where you're going to see it. The fridge is a common area. So having that constant reminder, like here's what we need to do to stay on task, here's kind of the expectations for today, and also having a little wiggle room as well. If things don't go how expected, like, all right, we have an opportunity to regroup. So, visual reminders is one that I'm very kind of, I like to use those a lot when working with families as well.
So some other classroom accommodations, these are just some examples if you're noticing a child gets up frequently. So something that's helped is visual cue on where to sit. So having a piece of tape if it's circle time, if they're young kids. On the carpet, say, all right, you're going to hang out in here. You can make a little box or make a circle, whatever the kid, let them pick what shape. So they're more motivated to sit on it. Having them sit in front of the class, like I mentioned before, or in the outskirts. Weighted lap pad can help, and movement breaks. So giving the child some tasks like, okay, you're going to help me hand out the worksheets to your classmates, or maybe have the whole class do some stretches, sing songs to really just get everybody moving a little bit because it can be hard to sit for 8 hours straight for any kid. Some frequent break ideas that you could try to incorporate in the classroom are bringing items to the office like the attendance I've had kids do, go to the water cooler, and say, "Do you wanna go get something to drink?" So they can, stretch their legs, having a break corner where they can, listen to music. And it's important that it definitely doesn't have highly preferred items, just because you don't want them to always want to go there and instead of sitting in their seat. It's just kind of an option for them to relax if, it's the class, all the assignments are too much for them and very overwhelming. It's a place for them to kind of take a break. So establishing a routine. So having a routine helps kids know what's expected of them. So something you could do is make that visual schedule I mentioned earlier with pictures or words, whatever's helpful. Most important thing is having your child make the routine with you, make that schedule. So this is just an example that I have that I've done with my students, my nieces and nephews, is have a small snack, then take out your homework, put on the kitchen table, um, let someone know what you're earning. So, hey mom, I want to earn my iPad today for an extra 10 minutes, or I want to earn extra TV time or outside time. Then have them complete the homework, clean up, put in backpack, earn that reward. So at the end, that's when you're earning that reward of that routine. So you can change it up however they want. The most important thing is to try to be consistent and follow through. At first, when you introduce a routine, I'm sure most kids are not going to be a fan of it, but it's important to try to just follow through as consistently as possible. Obviously, life happens, it's not always easy, but you just do your best to try to stick to it, and eventually they'll follow through with you. Okay, oh, there it is. Okay, so these are some examples of visual aids you can do. So on the left is a first then board. So first homework, then you can play your Xbox. So this is something I've used with lots of students. It's just a reminder that you can keep out on their desk or at home. It could really be used anywhere in the community. Very helpful. It could be words instead. The visual schedule on the right, this is an example of a morning and evening routine. You can really just make it your own at home or at school. So a lot of kids like to rip it off. That's very reinforcing for them. So after they brush their teeth, they take it off. And that's, really fun for some kids. They finish it, what's next? So that could be very motivating. You can have it written out. So crossing it off can be, a lot of kids like doing that or checking them off. I know I make a list every day and checking it off is very satisfying. So lots of kids prefer that or the pictures. You can really just make it anything you want. You can use it as a classroom or individualized. It's up to you.
I think, Natalie, we were also talking a lot of this stuff, like these choice words, first then, are readily available online. Like, we have no stake in
Hmm.
any of this, by the way. So, but if you look on Etsy, they have so many different designs, and it's maybe good to just sit down with your child, like, hey, which one do you like, to have them feel
Hmm.
a part of this process as well. And I agree. Like, I have my little index card of I scratch off. It just feels nice to accomplish something at the end of the day. You see what you got done, what didn't get done, and also reviewing that with your child, like, hey, we didn't get to basketball practice because XYZ. Not the end of the world, but let's see what we can do to make sure that doesn't happen again. So always kind of debriefing as well.
Some reinforcement strategies you try. So, positive reinforcement, everybody knows that one. You're adding something to increase a behavior. So, your child completes their homework, they earn an iPad or a sticker, whatever reinforcement your child wants to earn. And the next one is negative reinforcement. So, you're removing something that will increase the behavior, which can sound confusing. So, I'm going to give you an example. Your child completes their homework within 30 minutes. They don't have to complete the rest of their homework, or they don't have to go to their extra tutoring session. So, say if your child doesn't like doing math homework, you could say if you finish your math homework, you can complete your other assignments tomorrow, or you don't have to go to your math tutor. You're taking that extra work away, which will then motivate them to complete the assignment that they're dreading probably all day. So these are examples, like we mentioned before, the token economy and a choice board. So token economy can be individualized, like the one on the left, or it could be for a whole entire class, like in the middle. On the right is a choice board. So the choice board is what your child can earn throughout the day. So it's important to update it, whether it's in the classroom or at home, to show them what's available. I know this can be very helpful for many kids, just to know, oh, I forgot that I could, play with blocks, or that we even have this at school. So it's a good reminder for them. So you can say, okay, you're going to work for blocks today. You put it on their token board. So it says, I am working for it. And then underneath, you put the picture. It's important to check every single time they fill out their token board what they want to earn each time, because they might be satiated with earning car rides. They don't want to go on any more car rides. Okay, so what else do you want to work for? So it's important to kind of check in each time. A way to use the token board at home is it could be like a pacing board for some kids. So, they're on task, they're working on their assignment for 5 minutes straight, you earned a token. And then you keep going until you filled it up. Now they earn their break, or they earn TV time, whatever they want to work for. And then you start over. In the classroom, a lot when I was a kid, we had gold stars that we used. So if you were really good all day, you got to put the star next to your name. So I made sure to always listen to my teachers, stay in my seat, answer questions to earn that sticker. And that's something all the kids will definitely love in the classroom.
I've even implemented this in my office visits with like the token and whatnot. You know, kids know, like, all right, if I let Dr. B take my blood pressure without any issues, he's going to give me a sticker, or he's got something in his little drawer. I usually have little toys and whatnot I kind of share. So it's even improved like just office visits, not with just myself, but when they see other doctors as well. It's like, hey, this is how it's done now. So again, it's that reinforcement over and over again.
Okay, so some group contingencies you can use in the classroom. So, this is a behavior management system where a consequence can be a reward or something aversive. So, it could be provided to an individual or group or specific individuals in a group of people. So, the first one is an independent group contingency. Basically, the teacher presents a contingency to the whole classroom, but only the ones who meet the criteria can earn the reward. So it's an individual performance. For example, the teacher tells the class, if you get an 85 or above on the exam, I will give you a sticker. So if I get an 85, I get a sticker. But if my friend Sally gets an 80, she does not get a sticker. So it's on independent scores. And the next one is a dependent group contingency. So that's also known as the hero procedure. So the reward is for the entire class based on the performance of a small group of people or one individual person. So someone can either earn something for everybody or ruin it for the whole class. So if Johnny completes the math problems on the board, the entire class can earn extra time in recess. But if Johnny doesn't complete it, then the entire class does not get that extra time. So that's where the social component goes in. The last one is an interdependent group contingency, which is the all or nothing procedure. So teacher presents an assignment that all the students must complete in order to receive the consequence. So if everyone completes the math problems, numbers 1 to 5 correctly before lunch, you can have an extra 10 minutes of recess. So everybody has to complete the assignment, not just one person or a small group. So these are just some antecedent strategies that you can try, but if your child is still struggling to concentrate and it's affecting their schoolwork or home life, definitely contact your child's doctor.
Right. So thank you, Natalie, for sharing that. So kind of that next step is, why do parents, families come see me? And they usually come see me for a couple of reasons. And I've got this kind of fancy table here, but the ones to focus are the ones that are in bolded. And more times than not, families come to me, Dr. B, I'm getting a lot of letters from school, like, he or she is kind of disrupting the class, talking a lot, daydreaming. We're seeing grades kind of slip. They're a little bit more argumentative. Those are typically like the first line reasons that most families come see me. The other reason is also there's a family history component of it too. Um, they have trouble concentrating. They may have siblings that already have maybe ADHD or some developmental issue, or even the families themselves, meaning mom and dad, struggle with these issues. So it's not uncommon to people to establish care with me proactively, knowing that they're going to need some assistance later in life. They kind of saw it with one of their elder siblings, and they would want to just kind of get the ball rolling. But usually difficulty in school, behavioral changes, whether it be at school or at home, and family history are kind of really the main reasons most people end up coming to see me. There's other issues as well, but those are the kind of the main ones. We go to the next slide, please. And when it comes to concentration issues, focus issues, being distracted, being inattentive, it really kind of comes down for assessment for attention deficit hyperactivity disorder, which is one of the most common childhood disorders now that could start at an early age. Most of the kids I see that I usually work with usually have some sort of diagnosis between under the age of 12. This kind of persists on through adolescence and sometimes adulthood. And the demands of these issues with your concentration, focus, being attentive change based on the demands we have in life. The demands you have in middle school are way different in high school or when you graduate into, advance into college. So ADHD is a very encompassing diagnosis. There's a lot of kind of symptoms involved, and I always try to work with families to understand which symptoms are impacting their day-to-day functioning, causing some impairment. Next slide, please. So kind of coming back to the genetics component, of our kind of psychiatric conditions that I treat with child and adolescents, probably ADHD has the highest prevalence rate of heritability between parents onto siblings. Anywhere between, our most recent data suggests 75 to 80%. If a parent or a sibling has ADHD previously, their offspring will typically have it. Right now, we're looking at a 10% worldwide prevalence of individuals being diagnosed with ADHD. That has been increasing over the years. About 5 years ago, it was probably closer to 6%. And a lot of this probably has to do with one, less stigmatization of mental health services, asking for help, also individuals within, the media, whatnot, celebrities, people talking openly about their condition. So that also kind of has led to possibly an increase as well. Just to give you a little bit of insight in terms of gender differences, boys are more likely to be diagnosed with ADHD, usually 4 to 5 for every female. Not to say that females don't have ADHD, their symptom presentation is just a little bit more different. And I'll kind of get to that in a little bit. Can we go to the next slide, please? So I just threw in this table here. This is from the National Survey of Children's Health. And the most recent data they have is from 2011. And you could see that how it's been trending upwards of the total population. We started the middle line 7.8 up to 11. And you could also see there's a higher prevalence rate in males to females as well. I will say this, when we talk about presentation between males and females, typically when people end up in my office, if they have a male child, it's usually due to some sort of externalizing behaviors. He's disruptive, he's running around, he's breaking stuff, versus females tend to be a little bit more reserved in that sense. They have more of the inattentive symptoms where they're just they're a little bit shy, they don't want to ask for help, they're not acting out as their male counterparts. So I always screen for everybody that comes in, regardless of male or female, because you don't want to miss anything. Next slide, please. And this is just another fancy little bar graph that I wanted to put in just to kind of show you the sex differences between male and female. And you could see the percentage difference between the male and female, almost 13 to 4.2%. So just another representation of that. All right. And all right. So, when people come to me, hey, such and such, they're struggling, they used to be like an A/B student, grades are slipping, I'm getting reports that they're just, not focused. I catch them talking a lot to their neighbors and leaving their seat. These are all the stuff that usually kind of comes to my office. And with ADHD, I try to educate parents, like, this is not, a diagnosis I could figure out with like a blood test. It's not like diabetes. I could get a hemoglobin A1C. Here's where you're at. And here's what we can do, some interventions, whether it be medication, exercise, whatnot. It's a clinical diagnosis. And I ask like a series of questions. I also do certain forms that parents fill out, teachers fill out. And while I'm doing this, I'm also screening for other issues as well. So is this depression? Because if we're depressed, we also have trouble concentrating. We're not worried about anything else. We just want to stay inward with our feeling. When we're anxious, we're thinking about the what ifs. What if this happens? What if I don't do this? You're always thinking of the future. So between like depression, anxiety, you're never in the present moment. And a lot of the stuff that I deal with has a lot of overlap of symptoms. So attention is a big one. Disorganization is a big one. Lack of focus, irritability. These are all symptom overlaps between all these different conditions. So when I do my evaluation, I'm very thorough, not only addressing the primary issue, but making sure we're not missing anything else that could be really impacting them. And honestly, maybe this wasn't ADHD. Maybe this was depression issues, or anxiety issues, and we need to address this first and see how that helps. The other component is, with ADHD being a clinical diagnosis, parents often ask me, well, should we do additional testing? And that involves neuropsychological testing, which I'll get into them. I always ask parents, what's the utility of additional testing if we kind of have a diagnosis or we have a direction where we're going? And usually neuropsychological testing is also involved through significant learning disorders. And if you do those type of tests, it helps you kind of fine tune where you can help that individual out the best. and I'm going to go into a little bit of neuropsych testing a little bit, but I also want to share a lot of comorbidities with ADHD. You can see in the red on the bottom. I wrote ODD, that stands for oppositional defiant disorder. That's when individuals increasingly irritable, defiant, puts up fights against authority figures. Very common to have this with ADHD that's kind of unmanaged or untreated, anywhere between 50 to 80%. Anxiety is very common as well because over time, if ADHD concentration issues aren't addressed, the individual the individual feels less self-sufficient. They lack the self-esteem and confidence that they could perform at. So they just become anxious and don't want to do the work or become irritable. And the other component, a lot of learning disorders are associated with ADHD, anywhere between 20 to 60. So when I'm doing my evaluations, I'm making sure, like, where are we at? What reading level are we at? What language level are we at? How are our math grades? How are we able to kind of manage our grades? And do we feel like we are struggling in one area versus another? Okay. And next slide, please. So coming back to neuropsychological testing, kind of the main reason I usually talk to parents about pursuing this is to see if there's any significant learning disabilities that also affecting their concentration issues. So this could be dyslexia, dyscalculia, which is trouble in numbers, and I have one or two patients that do suffer from dyscalculia, and this was after we kind of went through the neuropsychological testing. And this helps because this could help the school identify how they can help the patient the best, whether that's through an individualized education program, so IEPs, and 504 plans. So IEPs are a little bit more, uh, I don't want to say strict, but they're more ordered in the sense that they have certain benchmarks they need to meet to help the individual get to the appropriate academic level for their age and station. Versus a 504 plan is, what are we doing to provide resources for this individual to have the best learning experience? So that could include like a little bit extra time on tests, maybe a delayed start time in school to help with anxiety. Um, the other reason, neuropsychological testing, if there's any concerns of head traumas, TBIs, concussions, seizures. So if I've had teenage athletes that play sports, and there was a decline in their attentiveness at school, concentration. So it's also helping to understand if there's any medical conditions that have affected their cognitive function. So when I do recommend neuropsychological, I try to coach parents like, hey, um, it does take a little bit of time. Most places, there is a wait list, and also there's a cost prohibitive component too. These things, most insurances, from what my experience, do not cover this. So this is something that parents often pay out of pocket. And I also coach them, like, when you go through neuropsychological testing, it is extensive, and your child is going to be subjected to like a battery of different tests. Sometimes it could be an all-day affair. Sometimes they split it over 2 or 3 days to make sure your child could kind of stay cognizant and focused during these examinations. So I really try to coach all the parents, like, know what they're getting into and what we're going to do with the results afterwards. Next slide, please. And this is the kind of come back to how Natalie started off our presentation. When I talk to family, there's like the psychological component and there's a pharmacological component. When it comes to like concentration issues, organizational issues, I always try to figure out what a day in the life looks like for that kid, for that parent. What does our morning routine look like? How do we get to school? Are we getting to the bus, drive? We get dropped off. What does our routine look like when we get back? Do we take like a 30-minute decompression break? Do we start working on our homework? What's dinner time? Helping me kind of plan out can help really understand like where we're having issues with. And the mainstay of a lot of ADHD treatment is therapy. Um, And specifically, I want to focus on like parent management training and parent-child interaction therapy. Those two combined, or either or, really help the parents kind of understand the presenting behaviors and how to best deal with it. And a lot of it, what Natalie touched on, is token economy, choice boards, and it's not only educating the child but the family as well. Because when parents come to me, I tell them, "Look, we are all working together. Even though your child's my patient, I'm working with you. I'm working with them. I communicate time to time with teachers. I'll talk to people like Natalie, like outside therapists and whatnot. So we all kind of work together, and I try to implement that. Like, and the first thing we do is try to educate. What does this look like? What does ADHD mean to you? What has it taken away from you? What struggles have you had with it? Kids that also have trouble concentrating, a lot of stress, a lot of anxiety. So one of the earliest things that we try to do, it's like, how do we deal with difficult situations? Are we yelling, screaming, breaking walls, or do we have a quiet space in our home, or do we have a break area in our school? Do we listen to like calming lo-fi music to keep calm? Do we go play with our dog? So helping an individual kind of build some mindfulness, some relaxation techniques is very important kind of early on. Families also benefit from support groups. Sometimes you feel like, man, this is only happening to me. You feel like you can't talk to him, but you'd be surprised. If I just went over the numbers, there's a good amount of individuals that are struggling with this. So maybe even connecting with another family member that may have a child that's struggling with this can help ease the burden and kind of help you understand. There's plenty of parental support groups out there for ADHD, concentration, developmental issues as well. The other one is CBT, or cognitive behavioral therapy. This is one that's usually reserved for like the teenagers because they have a little bit more wherewithal to understand their thoughts and feelings and behaviors around ADHD or focus and concentration issues. Because over time they build this identity. It's like, oh, I can't concentrate because such and such, and oh, because I'm dumb. And that dumb idea starts building like a snowball falling down a mountain, like bigger, to the point where they believe that's their narrative. And that's not true. That's just, they're struggling with something, but that's what they believe. CBT really challenges that and shows them the evidence like, hey, there's a point in time that you excelled academically. You were able to get all your stuff together, and something happened along the way, and that's fine. But there's evidence for it. And we try to disrupt those thoughts. Those are usually reserved for um, adolescents, teenagers. Next slide. All right. So, after we, had a lengthy conversation, I talked to them about all the options, recommendations. There's a good chunk that the patients that I work with, the families that work, that medication is warranted. And when I have the conversation of medication, I stress to them, we're using this as a tool, not necessarily the solution. And the solution will come as we work, and it's really going to come from the individual. And first of all, in terms of management for ADHD, stimulant medications have probably the highest response rate of all our kind of medications across the board for psychiatry, almost 70-80%. Those that are diagnosed with ADHD, roughly 70% do take medication. And when we talk about medication, it is, I go through all the options. There's plenty of options, different formulations. And there's the science to it, but there's art, and every individual has a different kind of regimen best suited to their needs. So we individualize this as much as possible. And we talk about risk, benefits, all that stuff. But what I'm trying to say is sometimes the symptoms can be so impairing that it could be difficult for the individuals to really engage in the therapeutic process. So if that is the case, I talk to families that, hey, we're at a 10 right now, 10 mean that was like, they're failing 4 out of their 5 classes, they're falling behind, they're likely to kind of repeat the 10th grade. Like, we need to kind of intervene, and we use this as a tool to kind of help get the individual on track, and hopefully helps them also engage in the therapy process as well. So between therapy, medication, those always two are kind of going hand in hand. Um, can we go to the next slide, please? So one of the things I want to kind of bring up, like, there are times when things don't get untreated. Things are brought up, things go by, and for whatever reason, they can't concentrate, whatever. And I bring this up because there's, talks of the moral compass shifting when an individual does not receive any kind of interventions. And the identity forms like, I'm starting to fail my classes, what's the point of even trying? You know, I'm disruptive, I'm talking a lot. It starts getting labeled the bad kid. Not a bad kid, they're just struggling with some stuff. Other kids don't know that. And other kids see them as a bad kid, or their parents may say, "Oh, don't mess with him." And I bring this up because there is a lot of studies now that have been done. So if you could see some of the pictures there, you see the young lady with the car. Individuals with ADHD issues are, have an increased likelihood of getting into motor vehicle accidents. The individual smoking a cigarette, more likely to engage in substance use. The individual on the top right, later in life, more likely to not hold a stable job, less likely to even complete high school, let alone GED. There's also increased rates of unwanted pregnancy as well with untreated ADHD. So understand there are downstream effects. And if there's always like a concern of something like, oh, they're just not concentrating, I know something's different, ask your doctor, come seek an evaluation. At least you kind of have an understanding to talking like, hey, what's going on? Is there something we're missing? So I see patients, in my office. I have 2 other colleagues as well, Dr. Yangchen and Dr. View here in Maywood. And we, whoever I recommend, if that's something you're interested to continue that conversation, we'd be more than happy to kind of do evaluation, speak to you, and kind of talk about next steps. So I think that's it I have.
All right. Thank you both so much. That was very interesting and informative. So at this time, we're going to do some questions. We did receive some ahead of time. If you have any that you'd like to submit now, please use the Q&A box, and we will try to get as many as we can answered. So the first one is, how can my child be helped in school if he has very minor symptoms of ADHD? What can the school do to support him?
So something that can offer him support is if he has a 504 plan or an IEP, like we mentioned before, start by talking to the teacher, maybe about updating goals on it or fixing his accommodations, whatever he needs as he's getting older. If he has a diagnosis, you can request an eval from the school to see if he will qualify for the 504 plan or an IEP to set up those accommodations, which would include strategies that we've both discussed in this presentation. Anything else you want to add?
No, I think just understanding like where the level of impairment is, right? Like, if it's minor, are there trade-offs to that? Like, are they still able to get their stuff done? And one of the things I also do with like coaching parents is like, how much is this bothering you versus it's bothering them and impacting them? Because we oftentimes operate at a different level sometimes than our child. So I always try to figure out what the level of impairment is and what are kind of the downstream effects if we continue with our current course without any interventions.
All right. The next question, which I believe you touched on as well. How do I help my child to stay focused and on task during school and then during study hours and at home without frustration?
So something to try initially is to figure out what is so frustrating about studying or the homework assignment. So is it the content? Is it the environment? Or are they just unmotivated to study? So once you're able to kind of figure out the why they're getting frustrated, you'll be able to work with them to decrease that frustration. So if it's the content, maybe the teacher can provide one-to-one time to go over it. If it's the environment, ask them what would help them. If it's too bright in the room, maybe dimming the lights, or if it's too loud, bring them to a quiet area. Things like that. And motivation wise, you can see what would motivate them. So using the first then board, choice boards, things like that.
Yeah, I would agree with Natalie on that.
Okay, next question is about slow processing speed. The son was diagnosed through neuropsychological evaluation. Any recommendation you can give? Will it get any better later in life?
I think that, in that sense, that's more individualized approach. The question would be like, what other supports do they currently have in their system of care? Like, are they in touch with adolescent medicine providers or developmental pediatrics, which are very well equipped to address these matters? And what type of interventions are they currently in place in the school? And it really kind of just depends on where they're at. It can improve, but there's always going to be some trade-offs as well. Like, there are certain limitations, and how can we best minimize the burden of those limitations? So kind of going back to that question, figuring out, are they involved with working with the pediatric neurologist, adolescent medicine? I know in Hackensack, we have the Institute of Child Development, which works with a lot of patients that kind of may present in that area, and we kind of coordinate care between the both of us. So they do a series of tests, examinations, they kind of follow stuff, and based on their recommendations, they'll maybe refer out to a neurologist for further evaluation, or they'll send them to me as well to, hey, can you just take a look at them or have a meeting with them and see if I'm missing something?
Okay, next question. What age is it okay for a student to lack concentration and interest in school or whatever they may be working on? Is there an appropriate age where you start to medicate? What diagnosis do you see with these type of children?
So in ages wise, it could vary. The youngest I've worked with was age 4. It's not uncommon for people to start seeing me in their high school years. And why I bring this up, because sometimes individuals have ways of compensating for these issues. And it gets to the point where they hit a wall, and they can't. So the demands in elementary school, middle school may not be as rigorous until they get into high school. And that's when like these symptoms of concentration, ADHD issues really start to rear its head. And when I do a little bit of deep dive, I feel like when I ask like the kids, like, yeah, even though I do good, I spend like 3 hours on this one subject to get this A versus my friend who studies for like 40 minutes and gets the same A. So you have kids that are probably figured out ways to compensate, but now they got into the point like, what worked for me then does not work for me now. So to that, your question, like it really kind of, again, it's individualized. I work I work with families usually starting anywhere between age 6, and medication is a topic that I talk to, how it could best help them, what are our goals for medication. And I always like to include the patient in the conversation as well, because I want, at the end of the day, they're going to take medication. They have to take it. So I want them to be informed um, in the process. So I always tell the patients, like, you are guiding the ship. I'm just making sure we don't hit an iceberg along the way.
Thank you. The next question is, what if there's no diagnosis and minor symptoms? What can be done to help in school? Can they get a 504 plan without a diagnosis?
That
So
one
it
I don't know actually. Maybe
yeah.
Natalie can answer that.
So it depends on the school district. But first, definitely try talking to the teacher, see what they're noticing, ways they can support them. It really depends. Are they in a classroom with 30 kids or are they in a classroom with 10? It really depends how much the teacher can accommodate. But if they're really struggling and falling behind, always, talk to your doctor. Maybe there is a diagnosis, and then the child study team can maybe write a 504 plan. It really depends on your school district.
Okay, and then this next question is, their child is getting elementary school education services and does have an IEP through their pediatrician. When should I seek support for formal ADHD testing with a neuropsychologist?
Well, I think if they have an IEP in place, what is the diagnosis listed in the IEP? Like, is it already ADHD? Because then someone's already established that diagnosis. And then um, with the pediatrician kind of diagnose, like, do they need additional evaluation, possibly from someone like myself, a child psychiatrist? And kind of going back to the neuropsych component, is this just ADHD or is there some sort of underlying developmental condition as well, or learning disorder? So these are all conversations to kind of have with your primary provider, and maybe also a referral to a specialist as well before even going down that path of getting a neuropsychological evaluation.
Okay, we probably have time for just one or two more quick questions. So the next one is, should I stop my child's natural fidgety energy and constant movement when he's trying to tell me a story or settle down for a bedtime?
Something that can help if they're very fidgety, you may think that there might be a sensory component. You could always reach out to an OT and get them evaluated for that to kind of help teach them self-regulating techniques. If there is a sensory component, maybe there's certain items that they can use to kind of de-escalate a little bit. Another thing that's been helpful is having like a bedtime routine for nighttime. So maybe like a warm bath, no screens, very just like calming activities at night, doing a puzzle, reading a book, but try to avoid screens at night because that seems to just activate some kids.
Yeah, and this kind of goes back to like initially when entering the therapy process, we like, how do we deal with stressful situations? What are we doing currently? And can we introduce new strategies to help kind of calm the body down, which inherently will calm the mind down as well?
All right, and you just brought up this topic, screens. We know that they're, not the best, but what are realistic recommendations to limit time spent on the devices? Their child seems to have longer concentration for a screen rather than reading, homework, board games, playing or sports.
So something that I've found to be successful, especially with teenagers or preteens, is finding because now they have based on like Xbox games or PlayStation games, they have books based on it or like board games based on it. So if they have a specific game they like to play, maybe trying to find something like that, or if they like anime, like watching it, they have books to kind of bring them away from the screen, at least for, a few hours a day, just give their eyes a break and their brain a break.
And I'll add to that, like, that is a challenge that I have with all my patients, just not those that ADHD. This is kind of a reoccurring theme. And where we are in society, screens are inevitable. I've got one on my watch, my phone, there's an iPad back here somewhere, and there's another laptop. Um, and schools, a lot of them, all the kids have Chromebooks. I'm aging myself. So I used to have textbooks. I didn't have a Chromebook or anything. So understanding how much of screen time there's going on, And what is appropriate is really individualized component. Like I try to encourage parents, like, let's find something for them to do without a screen. Are we going outside? Playtime, certain books, I tell them books are designed, if you really look at the page color of, like, let's say a Harry Potter book or a fiction book, they have this brown color to it versus a textbook versus like this bright white. They've done studies on that color, why those books are, it helps calm the body down. It decreases actually cortisol levels over time. And there's recent data to suggest that, I think it was published in the Lancet more recently, increased screen time over the years has led to increased like behavioral activation, emotional dysregulation. So it is an ongoing challenge. I wish I had like a better answer than saying, oh, only get 30 minutes of screen time, but that seems unrealistic at this point in time with the demands we have in life, school, and elsewhere. So for every amount of screen time, I'm focusing on what can we do without a screen time, whether it be building Legos, puzzles, crossword puzzles, like something else that doesn't involve a screen.
All right. Well, thank you so much, Dr. Barot and Natalie. This was very interesting, informative, and I know I'm definitely walking away with some tips that I can use with my kids or even myself. So I really appreciate you guys and sharing this information. And thank you all for joining today. Please watch your email for an evaluation of the program. Please take time to fill it out. We'd love to hear from you. Let us know if there's other topics of interest. The link for the recording would also be included. And then our next upcoming Parent Guardian Talk series is on coping with loss on February 29th. So please look out for that information. You can visit our website at hackensackmeridianhealth.org to find out more information about this one or other great upcoming programs that we have. So thank you again for joining us, and we hope you have a great day, and we will see you next time.
Thank you, everybody.